I've been asked to give a talk on chronic pain, which I will now share with you, and we'll get started if that's all right. Right, can everybody see that? A few thumbs up or something, just a
Yep.
reminder to let me know it's all okay.
Yeah,
Okay,
perfect, Josh.
right. Chronic pain in sickle cell disease, and particularly why more morphine may not be the answer. I think today. I wish I could say I was going to give you a really, really clear-cut explanation of what to do about patients with chronic pain in sickle cell disease. Sadly, I'm not. I'm going to be a bit of a disappointment. But what I want to do is really try and make people think a little differently about pain. And starting with this little quote about patients feeling that healthcare workers judge them as drug addicts and might downplay their pain. I think that actually comes as a quote from a paper about global experience of sickle cell disease published a few years ago in Lancet Haematology, but actually it also reflects pretty much what was said about 30 odd years ago when we started to look at how patients with sickle cell disease in the UK, what their experience of healthcare services were. So it would appear, sadly, that things may not necessarily have moved on hugely. So, what is chronic sickle pain in the first place? Well, the kind of international explanation or description of chronic pain in sickle is really chronic pain or rapidly cycling acute pain. And I'm hoping that many of you will recognise this sort of pattern of people in and out of hospital, either never really being pain free or having very, very tiny short windows of pain-freeness between their episodes of severe pain requiring strong opiates. And if that goes on for 3 months or more, then by definition, they've got chronic pain, really. It's very common, it's increasingly common in adults, but it's also seen particularly in the transition period in childhood. And we don't really know what the prevalence is, but it's up to about 30 or 40% in some series. The pathophysiology is not very well understood, and neither is the management. So great, good start. Um, so let's start off with, I think, what is partially was part of the problem for us as hematologists. So I'm just moving my uh, picture on the side. So sickle pain, what do you understand as doctors working in Zambia and in the UK? What do you understand by pain and sickle pain? So we know it's probably one of the most complex forms of pain that we look after. As a hematologist, speaking from my own part, I've received little or no training in pain physiology and pain management. I know about morphine. We use a lot of morphine in sickle cell disease. We've been using morphine in sickle cell disease as our primary our primary pain relief mechanism for many, many years, decades, in fact. And I kind of also understand from experience that repeated episodes of poorly managed pain cause more pain, essentially. So that's pretty much my understanding of pain, I reckon. And I think my sort of neuroscience understanding of pain is even more basic, and it's sort of pretty much outlined by what we see here. You know, a man who's or somebody who's done something to their foot, trodden on a nail, for instance, and pain fibers take those sort of the stimulus of the pain to the spinal column, and from there it travels up to the brain, and where it's processed through the thalamus and limbic system, and therefore and very often you get a signal back to move your foot or whatever from the offending injury. So that's, it's a pretty noddy, basic understanding of the pain pathways. And I suspect I'm not alone. If I've got any wonderful neuroscience experts in pain relief here, please argue with me and say you're an expert. But I think many of us have this fairly basic understanding of pain. Um, so what is pain? Well, the formal definition is it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So essentially, what does that actually mean? It's quite complicated, isn't it? It's not a very clear, not a very clear explanation. So I think what it means. a phrase like actual or potential tissue damage or described in such terms means that pain is enormously subjective and very much individualized. So one person's pain is very different to an experience of pain is very different to another. Physiologically and in terms of survival, it's a warning sign. So pain is telling you something's wrong and you need to be wary of it. It's your body trying to defend itself. So it's a protective system, if you like, but it's one that can get manipulated and can work against you as well as for you. So its stimulus can be physical and or mental in nature. So it's not just a physical issue. It's a very much how we interpret pain is just that, is how we interpret it in the setting that we're in. So, you know, it's very easy if you are hit by something very heavy, you can see it happening, you can understand that that's going to cause you pain. But sometimes pain can be misinterpreted. So, a minor scratch on your leg that turns out to be a poisonous snake bite will not be interpreted in the same way, even though it's a very, very severe issue. And, there are plenty of stories and from, within war zones and huge trauma areas where people with apparently phenomenally serious injuries seem to be able to ignore those to escape the sight of physical danger. So it's very much an interpretive phenomena, a subjective phenomena. It interferes greatly with relationships if they're for the long term and will very much influence how you feel about your own life. And really, perhaps one of the most important things, particularly when you're dealing with any form of pain, but for us talking about sickle patients, is only the patient themselves know whether pain is present, and they have the experience of how it feels, not us. And it may not be proportional to the amount of tissue injury. And I think that's a difficult concept to get into your head. And I think with interpreting, as a doctor, trying to interpret somebody's pain, it's very straightforward. If you have somebody's been knocked over by a car or something, and you've got a fracture which is visible and extensive hematoma and bruising or whatever, you can see that the injury is there. You can see that that would cause pain. With sickle cell disease, it's often completely invisible to us, and we have to, under all circumstances, listen to the patient's description of that pain and that severity, because that is what they're experiencing. So we're living in a bit of an educational void. This was what Mr. Dr. Solomon said some 10 years ago in a paper in the in Blood, the Journal of the American Society of Haematology, and really I think it still stands today. There are limited knowledge regarding the principles and appropriateness of opiate therapy and a lack of evidence-based research on pain control, and also some misconceptions and prejudice about drug abuse and drug addiction contributing to this educational void. I don't think, in all honesty, that has changed a great deal over the last decade. So what about the pathophysiology of pain in sickle cell disease? Well, we'll just run through this. I mean, obviously, all of us know about the hemoglobin S abnormality. We all know, I hope, that if you in low oxygen saturation, that this hemoglobin S will polymerize, and those polymer bundles will interfere with the red cell membrane, such that that red cell has a shortened life. So you get hemolytic anemia, and also eventually this red cell will end up looking like an irreversibly sickled cells, for which the disease that we're talking about is known. And the hemolysis itself, hemoglobin is normally packaged nicely inside red cells, kept away from the endothelium. But if you then have free heme, you get endothelial disruption, you will get changes which result in chronic vasoconstriction. The free heme also drives inflammation, sterile inflammation, and the effect on the sickle cell, on the red cell, which this actually is slightly wrong, this diagram, because it's not necessarily the sickled cells that actually are the ones that the culprits of vaso-occlusion. It's more younger cells, the sickle reticulocytes, in fact, which are the sticky ones that stick to other cells and endothelium and platelets. But so you get a physical occlusion of precapillary venules. You get again, and further, the hypoxia drives further sterile inflammation. So you've got a whole combination, multifactorial vaso-occlusion going on, which drives the pain in sickle cell disease. And the bone marrow compartment itself is the area that is affected in painful crisis. And interestingly, the bone marrow compartment itself is a hypoxic area. So the oxygen saturation within your bone marrow is less than obviously than in your bloodstream. So it's a great hypoxic area for a sickle cell for hemoglobin S to polymerize and cause more damage. And that I suppose that is maybe one of the reasons why painful crisis, bony painful crisis, is so common. But these are not usually chronic events. These are usually intermittently unpredictable and very severe events of acute pain, not necessarily chronic pain. But chronic pain, as we said, is very much a phenomena that we're seeing more and more. And we do know that if you have recurrent pain or chronic pain, that your outcomes are poorer. So it's a marker of poor disease control, and it's a marker of shortened lifespan. So severe frequent pain or chronic pain translates to reduced lifespan and a poor prognostic factor in sickle cell disease. So how do these opioids that we use reduce pain? Well, their principal action is in the dorsal horn of the spinal cord, and they reduce neuron sensitivity to the painful stimulus. They also have an anti-inflammatory effect, but there is also this very powerful central effect within the brain that reduces your emotional response to pain. So that's how opiates work, but can they do harm? I think we'd all agree that yes, they can. And I'm going back here again a good many years to when in the UK we did a national confidential inquiry into patient outcome and death, specifically from sickle cell disease. And a good number of the deaths we saw over a year's period in the UK could be attributed to poor opiate management and opiate overuse. So I don't think that this is a phenomenon that is unique to the UK. It's certainly seen in the US as well. The opioids that we use to manage our patients are potentially harmful. They're a dangerous drug. And there is an association with excessive side effects with various toxic metabolites, with opioid-induced hyperalgesia and central sensitization that I'll come to later. And what's more, very importantly, I think both doctors and patients have a poor understanding of what we're trying to achieve in the use of opiates and what those risks are. And I think this is one of the themes of this talk is really, I don't think, unless we have specifically trained ourselves up, we are very well qualified as individuals to manage this very complex area of pain that we end up dealing with. So I'm going to give you my own personal experience of doing a very bad job of managing recurrent acute or chronic pain in a sickle patient. I apologize for this slide. It's over 30 years old, which is why it doesn't look like it fits on the screen very well. It's a picture of a picture. But I worked in Jamaica for a number of years in my early days of haematology. And this is one patient. And in Jamaica, we had this day case arrangement rather than a hospitalization for every patient. And the patients would turn up at the clinic, the sickle clinic, in the morning if they were in pain. And if they were very, very sick, obviously they had to be admitted to hospital. But many patients received injections of pain relief during the day and then had a few days of strong painkillers to go home with. And most of them managed by doing that. I think it was a very good model of care for these patients in a specialist centre. But this poor lady was somebody I unfortunately got to know very well. The yellow line is the number of attendances at the clinic requiring strong parental opioids. And the blue line is requiring more moderate opioids. So as we can see, for the first 20 years or so of this girl's life, this young woman's life, she made very few attendances. She had sickle cell disease, which was relatively well controlled, seemed relatively well managed. And then in her early 20s, as a young married woman, she became pregnant and unfortunately suffered an intrauterine death. So late pregnancy, intrauterine death. Enormously traumatic experience for her, unsurprisingly. And at that point, she started to attend the clinic much more frequently, and uh, with frequent pain, severe pain, requiring parental opiates. The pressure of this perinatal death and her depression uh, caused quite a lot of marital disharmony. And eventually, her husband decided that he was just going to go to Miami. He left her. At that point, things looked like they got a little bit better, which my wife says she completely understands, but I have no idea of the reasons. And but things temporarily improved, but only for a matter of not for long, because shortly after that she developed osteomyelitis, chronic bone infection, another complication of sickle cell disease. And at that point, she was hospitalized for a long period of time. She had multiple episodes of surgery. She, as a consequence of that, lost her job and lost her income, lost her home. And then, really, beyond that, the poor woman is a disaster, really. She's in the clinic 1 or 2 times a week, every week of the year, requiring strong parental opioids. So she is this sort of revolving door patient that perhaps we've all seen. And I suppose my question to you based on that is why do we think her sickle cell disease is so different in those second 2 decades as opposed to her first 2 decades? And what I want to try and encourage you to think about is her total pain burden. So, what was going on for this woman that made her sickle cell disease so much worse? Was it just that her sickle cell disease has suddenly got worse, or was it more complicated than that? Well, certainly we as doctors were undoubtedly contributing to this awful situation she found herself in. She was getting high dose opiates some days, and then no opiate days, no opiates other days. The clinics weren't open at the weekends, so she wasn't getting any opiates at the weekends unless she had any left over. So she was having poor opiate management, and she was having cyclical withdrawal from opiates. She, at this point, had a degree of sort of she was lonely. She'd lost her income. She lived in poor quality housing. She had a poor diet. She probably had undiagnosed depression. She'd lost the infrastructure that surrounded her, that supported her. And this so in other words, this is much more complicated than just sickle cell disease. You have to take in the whole life effect of this individual to understand the severity of her pain. And my next question to you is how many of these factors are going to respond to increased opiates? And in fact, how many of them are actually of medical origin? So let's go back. So most of these are nothing to do with medical management or opiates. In fact, other than undiagnosed depression and untreated depression, the things that actually are driving her pain from a medical point of view are poor opiate management, cyclical withdrawal, which we'll talk about, all of which we'll talk about later, and opioid-induced hyperalgesia, again, we'll talk about later. So some of this medically was iatrogenic. It was our fault, my fault. I was prescribing poorly for this patient and not helping her situation and completely ignoring all these other aspects of her pain. So I think that's an important message that I eventually walked away with, and something perhaps we all need to consider a little bit more about these patients with pain who are very difficult to manage, and there are lots of reasons for that, but I think we need to bear that in mind. So back to the characteristics of sickle cell pain. So we've got the standard sort of nociceptive pain receptor type acute pain related to ischemia, infarction, and inflammation. We've got a neuropathic component and obviously a mixed component for acute pain. With chronic pain, there are obviously anatomical causes that you can point a finger at, do an X-ray for, see the ulceration on the leg. But there are a whole host of other things that we can't quite so easily define, a complex interplay between prescribing issues, social issues, psychological issues, and other physical issues in the setting of a chronic illness. And then this group of drug-related issues, where the morphine itself, the opiates themselves that we use as our one of our limited array of tools, may actually be contributing in these situations where you've got repeated pain and repeated admission. So our rationale for prescribing in pain is obviously the inflammatory, the acute pain episode will respond well to non-steroidals and opioids. The neuropathic, neural infarction, vascular complications around nerves, that too will respond to opioids, but also to other drugs like pregabalin, gabapentin, and duloxetine. The tolerance that patients get with long-term opioids can be dealt with to a degree by switching opioids and actually by, in some respects, reducing opioids rather than increasing them. There are some opioid subtypes which are less prone to cause this hyperalgesia, which I'll talk about in a minute. And I'm not really going to cover the severe I don't really want to talk too much about short burst IV ketamine other than to just mention it, because I think that's fraught with complications. And talking of complications, I think it's important to remember that opioids themselves, as we've discussed, are dangerous drugs. Constipation is a very common side effect. Sedation, particularly with escalating doses. Patients do suffer with pruritus, nausea, altered cognition, and in the long term, men particularly can develop hypogonadism and impotence. So these are not safe and complication-free agents that we are using. So, in such a patient who you are seeing very, very frequently, or is in chronic pain, or recurrently admitted with very short cycles of acute pain, how does our opioid prescribing contribute to their pain? So, the pain itself can recurrent pain itself can induce long-term changes in the CNS, and opioids can exacerbate that. So actually, the very experience of recurrent severe pain or long-term chronic severe pain can rewire you as in terms of your experience of pain, is what I'm saying. Um, so increasing opioids will cause a degree of tolerance, and we get this thing called central sensitization, which both from the effect of chronic pain on the individual and the effects of opiates. And this central, you become more sensitive to the pain, and that's what leads to the symptoms of central sensitization, which are called hyperalgesia and allodynia, which I'll come to in a minute. Morphine is a commonly used analgesic, as we know, and over a prolonged period will contribute to all this. Other drugs are less likely to give this problem, but again, some of those have their own issues and may not be appropriate for the management of sickle pain anyway, in all settings. So, opioid hyperalgesia. So, there's an increasing body of evidence that shows the evidence of these changes. Um, and I think the characteristics, and you may recognize this, is basically a disproportionate and an atypical form of pain. It's a maladaptive adjustment to pain. So if we think about here the curve on the right here, that if you touch a patient's skin who has a normal response to pain, they don't feel pain, they feel touch. If you prick them with a pin or put pressure, then depending on the level of that pressure, they may feel a level of discomfort or pain, but they will get this sort of normal response to a rising stimulus, a rising noxious degree of a noxious insult, if you like. And central sensitization leads you to shift that curve completely. So the patients who you might see, some of these patients may report this, that even mild touch can induce pain. It can trigger a painful response. You get a disproportionately severe response to a mild stimulus. And that's allodynia and hyperalgesia. And these are the features of central sensitization, and very often chronic pain in sickle cell disease. So it's worth asking these questions of patients. It's often accompanied by depression, mood change, poor concentration, sleep disturbance, sort of brain fog as well is sometimes something that's reported. So I think what I'm trying to get at is just be aware that just steadily, if you see a patient who's getting more and more pain, your response sometimes is that you just increase the opiates. And that may not have any benefit, and indeed it may actually be making things worse, particularly in patients who you start to realize that their pain manifestation isn't necessarily typical for an acute painful crisis. It sort of shifts locations. One minute it's here, next minute it's on the other side. It's not like the characteristic pain that you might see in a patient for an acute painful crisis. This is not addiction to opiates. It's not opiate seeking behavior. It's really a pharmacological dependence and a rewiring of your ability and your experience of pain. Uh, and therefore, this type of pain, if you identify it as such, and there is no hard and fast definition, so it really is very much understanding your patient and listening to what they're saying. Um, so you have to base it on your own individual clinic assessment. There's not a particular test that tells you whether somebody has central sensitization, chronic sickle pain, that is going to be of the type that is deteriorating because of your pharmacological practices. And I think so. This was published in the New England Journal a year or so ago, and I think sort of describes it pretty much. So this is central sensitization, repeated nociceptive pain, repeated normal pain insults result in neural changes which enhance pain sensitivity, anticipation, and aversion. Synaptic networks involved in emotion and cognition prioritize painful stimuli over pleasurable ones. I mean, that's a method of survival. You prioritize you don't your body does not want you to ignore pain. It wants you to pay attention to it because that is a warning sign. So it's a survival mechanism. So that's something that happens anyway, but this is exacerbated in these patients. And then if people have had a history of recurrently poorly managed pain and so if they wait in A&E, if people don't trust them, if they can't access medical care, if they're given inadequate treatments earlier on in life, then the emotional trauma that associated with their past pain experience enhances their negative emotions and makes future episodes more difficult to manage. So what you're left with is a subjective experience of pain which is much worse and persistent and overwhelming, and even in the presence of relatively minor stimuli. So I talked a bit about poor analgesic management exacerbating this problem. We talked a bit about hyperalgesia and allodynia, and this cyclical opioid withdrawal syndrome, which these patients who present on a recurrent basis are particularly prone to. And you might recognize this pattern. Somebody presents with acute severe pain, is hospitalized, they get high dose opioids, their pain gets a little bit better. They maybe don't have an opioid taper, their opioids are just stopped. They're discharged. They then get withdrawal symptoms from opioids, which are very similar to sickle crisis, with a recurrence of joint pains, and then get readmitted, and around we go. And this is this cyclical withdrawal problem that we see. So, few tips on tapering opioids. In all cases, in short-term use, once your patient's pain has reduced to a manageable level, and they're not on any parental opioid, then you might still require strong opioids tapering over the next 5 to 10 days. The length of taper really depends on the patient themselves, their history, and how they respond in the past. So you have to know your patients. And then ultimately you can switch them away from the strong opioids onto moderate strength drugs, and then hopefully and get them off those, because those too are addictive drugs in the long term and should not be used in the long term. No hard and fast rule to this. Know your patient. In chronic usage, it's even harder. Patients have often been on opiates for a long time. They require a very, very slow, very, very closely managed taper. The patient has to be completely involved with this process. It's not done to them, it's done with them. And the dosage, as I say, has to be reduced very slowly. There are inevitably going to be stops along the way, times where may need to go back up again, as this is a condition associated with recurrent pain anyway. Very close reviewing, very close interaction with the patient and other clinicians. And it is a many step process that doesn't always work out first time. In an ideal world, in a patient with this chronic form of sickle pain, this is the kind of team that you need. Now, most of us, whether we're in the UK or in Zambia, can't muster this. But I show this primarily to kind of highlight the nature, the total pain nature there, and the total solution that you need. So you need not only your expert hematologists, but you need pain management experts. You need people who will understand mental health issues and offer psychological support. You need to be certain that your pain control protocol for that patient may well be individualized, not just a generic one, and that has to be communicated with other specialties that they could present to. Physical therapy, physiotherapy may well be advantageous. A low degree of exercise is often mood lifting and may help patients in these sort of situations. You need to liaise with your primary care colleagues if you have them. And very often in the UK, we try to engage with social support services, community support to to deal with the almost inevitable difficulties that these patients are having in their lives outside hospital, which impact on the severity and pain and the frequency of their admissions. So you've got to integrate all this lot. You've got to have non-hierarchical discussion that includes the patient. You've got to have people need to be educated about this, because I don't think people really understand the complexity of this very often. And individuals of protocols of care, which include physical care, social care, psychological care, agreed with all parties. So it's a difficult and complex process with a high rate of failure. So total pain burden requires a total care package. You need to manage the whole thing. So you need to manage the opiates, you need to manage the sickle cell disease. So the patient needs to be on drugs which will modify their sickle cell disease, where that may be hydroxycarbamide or transfusion most commonly. You need to manage the other aspects of their medical care, um, their mood disorder, laxatives, other supportive measures, and they need support. They need support in psychological terms. They may need support in physical terms uh, as well. So it's a very complicated process. Um, so I'm reaching the end really, but I think the important message is these are very complex cases. They're increasingly common. It's not necessarily just the sickle cell disease that's causing this. That there are not that many causes for sickle pain. This is very often a multifactorial, complex psychosocial interaction contributed to by poor analgesic management by doctors like you and me, which make things worse in some respects. Opioid dependence remains a very unusual thing in sickle cell disease. So I think, as hopefully I've explained, it's very difficult to manage this. So therefore, you're better off preventing it than trying to cure it. And that comes from education of doctors involved in the care of sickle cell disease and nurses involved in the care of the sickle cell disease, the patients themselves, very careful opioid use, make sure you taper properly. Progressive escalation, where progressive escalation becomes unhelpful, then really stop trying to do it and start to think of other ways. uh, modify the disease with hydroxycarbamide transfusion, manage depression, manage neuropathic pain. Recognize that this requires a multidisciplinary team approach and is not just an issue around analgesia. And that's pretty much it. I just wanted to sort of leave you with this last slide. So this is back to the rewiring issue. So right at the beginning, we showed the little man who's got a pain in his foot, and a very sort of very simplistic view of pain science. Um, but I think what it didn't really highlight is what's going on in the brain. And if you look at functional MRI scans, you in sickle patients with three or more admissions into ED or hospital a year compared with to those with two or less, they have very different patterns of brain connectivity. So your whole central neurological system, your frontal cortex, your limbic system, the way this is processed in these patients is entirely different. And I go back to the argument that just using morphine in these situations is not going to be helpful. And I think this is actually morphine hammer is a play on words. It's Maslow's hammer. Maslow was the guy who talked about the hierarchy of needs, if you're familiar. But Maslow's hammer, if the only tool you have is a hammer, then every problem becomes a nail. If the only drug you've got in your armamentarium is morphine or an opiate, then you think of everything in those terms. And I'm trying to encourage you not to. So that's my simplistic view of pain, chronic pain in sickle cell disease. Um, you're probably as confused as I am about it, but if you have any questions, then please ask. Has anyone seen patients like this?
Josh, I was just going to make a comment really. Thank you for your talk, really interesting. But from a nursing point of view, I always remember it brought back memories of a conference talk I did where a nurse and a doctor were present, and the nurse actually started crying because she felt really ashamed that years prior, her and the doctor didn't believe a patient was in sickle pain, and they ended up giving him water for injection as opposed to an opioid, and she was, she was really distressed by that, and she admitted to it happening. But again, it goes back to your talk about that misunderstanding around the chronic pain and the acute pain, and just the lack of knowledge really around sickle cell.
I mean, I don't think it's, I mean, I think it's a horrible story,
Mm.
but I think, I mean, in truth, with my patient back in Jamaica 30 years ago, it was just difficult. And I didn't, nothing I was doing was making much difference. And I just used to dread seeing it, to be honest. It's so your own emotion to those patients is very important. And it's very important to reflect upon those too. These patients are not a nuisance. They are people with genuine complex chronic pain syndrome. And actual fact, if you look at rheumatology literature and other diseases and chronic back pain, this pattern of central sensitization, rising opioids, and the need for a multidisciplinary approach is matched across a lot of. It's almost a final common pathway for chronic pain, basically.
And
It's not just sickle
thinking
cell disease.
holistically, isn't it,
Mm.
about it rather than, as you say, just morphine
I
through
think
the
sickle cell
nose.
disease adds in a whole host of extra complications because every one of these patients with chronic pain, which may not respond to opiates, may well have episodes in the middle of all this that re absolutely require opiates for an acute episode. So it just gets very, very difficult.
Thank you.
Thanks, Danny.